introduction. I'd like to thank the Ehlers-Danlos Society for their kind invitation to have me here today, and it's wonderful to be here with you all, ladies and gentlemen, to share this conference. So I've got some challenges this morning. It's reasonably early. It was Friday night in Vegas last night. I'm sure you had all the wonderful time at the ball. Many of you had to check out of your rooms this morning, so I appreciate if some of you may drop off, but I hope to keep you inspired and enthused. So what I'm going to talk about today really is how we developed the link between EDS and GI symptoms. And it was fascinating to see how many of you, to Laura's question, put your hands up, and that's really been our experience in clinical practice. I'm going to look at some of the implications of chronic abdominal pain and how to treat it and maybe not how to treat it, look at some of the pain pathways that are involved in the genesis and maintenance of that pain, and look at some treatment approaches. So I want to take you on a road of enlightenment. And this was a patient my mentor and I, Professor Kazim Aziz at Barts and the London, saw nearly 10 years ago now. And we were the 16th set of gastroenterologists that this lady had been to see. And she came into our clinic room in her wheelchair. And she had multiple symptoms for many years. And I never like to ask why people are in wheelchairs because I get a little bit embarrassed about asking that question. But Kasim said, "Why are you in a wheelchair?" And she said, "Well, I have this connective tissue disorder called Ehlers-Danlos syndrome." And this really was our first index patient that got us thinking, could there be a link between these connective tissue disorders and the seeming myriad of GI symptoms? So what do good doctors do? They go back to the literature. And we found this paper from Rodney Graham and Alan Hakim, which had been published in Rheumatology about 3 years prior to us seeing that patient. And what we found, to our amazement, that actually in patients with joint hypermobility syndrome, as there was the nomenclature at the time, actually GI symptoms were very common. So we started looking into this then in a little bit more detail and somewhat more systematically than we had done before. So we looked at our cohort of patients that were coming to a tertiary referral neurogastroenterology clinic in London. And to our quite profound shock and amazement, we found that nearly half of the patients coming to our clinic had evidence of joint hypermobility. And this was something that we hadn't thought about and hadn't looked before, but once we started looking, we started finding it. And moreover, we found that those patients who had a cause or an explanation for their symptoms was much lower in those with hypermobility than those without. So we then began to characterize the gastrointestinal symptoms in patients with EDS, then in a larger cohort of patients. And we looked at nearly 600 patients who came to our clinics. And we asked them to complete a number of validated questionnaires looking at bowel symptoms, some of their musculoskeletal symptoms, autonomic symptoms, and some of their anxiety and depression scores. We also classified them as to whether they had evidence of generalized joint hypermobility and JHS. We also had to have some positive control groups, so we had a proportion of those patients who didn't have hypermobility, some that did, and then we also had a positive control group from the rheumatology clinic as well. And if we looked at the prevalence of the various symptoms across these groups, we can see that particularly abdominal pain, heartburn, so reflux type symptoms, and water brash were very common, but also feeling full after they'd had a meal, so what we call postprandial fullness. But when we compared and looked at the trend across these, so we presumed that those that had mild generalized joint hypermobility were slightly less, had a less severe clinical phenotype than those with rheumatologically diagnosed joint hypermobility syndrome. We can see across all of these symptoms that actually there's a trend across the spectrum from normal to severe disease. And when we look at some of these symptoms in somewhat more detail, we can see that constipation, diarrhea, delayed gastric emptying, or what we refer to as gastroparesis, are really common symptoms in patients with joint hypermobility syndrome. When we began to delve down a little bit further and start trying to put some diagnostic labels on these patients, we could see that particularly the functional bowel disorders were very common. And this is when we adjusted the data based on age and gender differences. And we can see that those with joint hypermobility syndrome have approximately 1.5 times higher risk of having one of these disorders in comparison to the general population. But not surprisingly, abdominal pain was also very common, and disorders where patients have difficulty evacuating and opening their bowels was also common. And I have to be honest with you, this came with a great deal of skepticism in the gastro community. This was something that was particular to our clinic, particular to our referral patterns, and actually we were by and large shouted down by a number of groups that said this is just a false association and is not really real. So we were delighted to see the experience from the Mayo Clinic. So they published a paper in 2015 where they described 20 years of experience in nearly 700 patients with EDS. And very similar to our data, over half of these patients had some form of GI manifestations. And again, the most common ones were abdominal pain, nausea, constipation, heartburn, and irritable bowel-like symptoms. So I hope you can begin now to see that there's a pattern here. It's not just one centre in London. This is seen in a number of centres now. And there's data from France, again, which replicates this. So I think the tide is really changing in terms of really educating the gastroenterology community as to the link between these two disorders. But what about the difference in terms of EDS and other connective tissue disorders such as Marfan's? And this was some fascinating data which some of you may have taken part in that was been published in abstract form at Digestive Diseases Week earlier this year. So this was a group of nearly 2,000 patients with EDS and 600 patients with Marfan's, and they compared the symptoms and diagnoses across these two groups. And you can see here that the EDS patients had much more IBS with diarrhea or constipation, but again, heartburn, functional dyspepsia, which is characterized by feeling full after eating and pain in the upper portion of the tummy, as well as cyclic vomiting. So actually, this does seem to be something that's reasonably specific to EDS when you compare it with Marfan syndrome. But if we just think about abdominal pain now, and this is really very important, because this is often very, very difficult for your physician to treat. Certainly, we've shown data that it increases in prevalence and severity with the increasing severity in the EDS phenotype. There's an idea amongst doctors that actually we don't really have much to treat patients with. It's really a symptom-based diagnosis. There's no useful test in way to make a firm diagnosis. And even these factors are even compounded by the fact that even the great and good across these disorders fundamentally disagree on the underlying cause of symptoms. So you heard a lot yesterday about criteria-based diagnosis in EDS. I want to just talk you through now the criteria-based diagnosis in irritable bowel syndrome, or IBS. So this was first proposed by Manning in the late 70s, where IBS was considered to be linked with abdominal pain that was somehow related to change in bowel movements. It was generally relieved by defecation, a little bit of abdominal bloating, incomplete evacuation, diarrhea with mucus, and so on and so forth. And I think this diagnostic criteria has changed over time with the Cruis score in the mid-80s and subsequently the systemization of this diagnosis through the Rome Foundation, now in its 4th iteration, which was published last year. And I think this has a number of salient messages for the diagnostic criteria in EDS, in that this diagnostic criteria is by no means perfect. But what it has helped, particularly the GI field, do is compare apples with apples in research studies. So actually it has improved the homogeneity, the similarity of participants in research studies that really has enabled us to translate results from clinical trials into improved patient outcomes. But some of the helpful things to come out of this, I think, if you think about the diagnosis of IBS, so it's got to be there for a period of time. These patients often have frequent consultations for non-GI symptoms, so that, you think about the musculoskeletal symptoms, particularly salient to EDS, lots of medically unexplained symptoms, and that stress often aggravates symptoms. There are some alarm features which we always think about, particularly those in the older age group, a short history of symptoms, weight loss, nocturnal symptoms, and so on and so forth, and that might point you to a diagnosis that's not IBS and maybe more like a cancer or something more sinister. But if we now delve into the Rome 4 diagnosis of IBS, this is now defined as recurrent abdominal pain at least 1 day a week over the last 3 months, which is associated in or related to defecation in some form, associated with a change in frequency or form of stool. And this criteria has to have been fulfilled for the last 3 out of 6 months. So this diagnosis that was published last year has really fundamentally changed how we diagnose IBS, and it's become a much more stringent criteria. And the main change in that criteria is that patients have to have pain at least 1 day a week. In the Rome 3 criteria, it was 3 days per month. So it has raised the bar. And I would argue that actually this is very similar to what we've seen now in the 2017 EDS classification. Does that mean that patients who do not meet that diagnostic criteria don't have bothersome symptoms? No, of course it doesn't. But it really does help us as academic clinicians to begin to perform clinical trials and perform research which ultimately, we hope, ends up in patient benefit. So we can begin to subtype irritable bowel syndrome, broadly speaking, into 4 groups. So those patients who have IBS with constipation, those who have IBS with diarrhea, they're fairly self-explanatory. But there is a large group in the middle there that alternate from one to the other, what we call IBS mixed. There's also a smaller group called IBS-U or IBS unclassified, which doesn't quite fit into one of those 3 aforementioned categories. But if we look at the epidemiology of IBS across the world, we can see that actually this is a prevalent disorder. So if we're thinking in the US, it's about 15%, a little bit less in the UK, a little bit more in Europe. But I would argue that it's around about the mid-teens in terms of the population prevalence in adults. And if you look at the age in which this diagnosis is generally made, it's a diagnosis of young adult life, by and large. And that's why I say if you're having a patient presenting with symptoms de novo over the age of 50, one might think that actually you'd think of an alternative diagnosis before IBS. But it actually occupies a huge burden of disease. So certainly in primary care, approximately 3% of all consultations are for IBS. And you think 3%, that's not very much. But if you think of the hundreds of thousands of primary care consultations that happen across the US and Europe every day, actually this translates into a huge burden of disease. And moreover, in secondary care, approximately 40% of patients who come to secondary care with unexplained symptoms subsequently get labelled with a diagnosis of IBS. What predicts that healthcare seeking? Well, certainly in my experience, and the evidence would suggest that actually chronic abdominal, chronic tummy pain actually is the greatest predictor for healthcare seeking. And also what triggers that referral from primary care into secondary care? Well, it's severity and chronicity of symptoms, and as well the patient's beliefs. What is the patient worried about? They often feel a lack of reassurance, and they're always worried, is there an underlying cancer? In terms of the socio-economic impact, IBS probably reduces work productivity in terms of patients missing days from work or school. There's this emerging concept of presenteeism, so patients actually do make it into work, but when they're at work, they're not productive. And the annual healthcare costs in the US per IBS patient are in the order of $5,000. So if you translate that up, 3% of primary care consultations, $5,000 per patient, 15% prevalence in the US. I hope I can convince you, ladies and gentlemen, that this actually costs the US a huge amount of money per annum. And indeed, the latest estimates suggest that worldwide IBS costs in the order of $14 billion for the global economy. So this is a huge socioeconomic burden. But if we think about quality of life in these patients, and if you just see here, you can see in the green line, healthy, those with reflux disease in the purple, and then in the grey, those with diabetes. And where do you think IBS comes in relation to these three other prevalent conditions, one of them being health? Well, not surprisingly, it comes right down here. So actually this has a huge negative impact on people's quality of life. So where are we in explaining this disorder? Well, broadly speaking, there are four aspects to IBS and chronic abdominal pain. There's certainly aspects centrally, so psychosocial abnormalities. There's changes in motility, i.e. the speed of movements within the gut, changes in sensation and sensitivity of the gut, and changes in how those signals from the gut that go up to the brain are processed. But ultimately, the end result of this is pain and discomfort. So I'd like to now introduce you to a concept known as the brain-gut axis. And this is a circuit of communication that goes from the gut to the brain and back again. And this is intimately involved in the perception of the internal state. So what's going on in the background in terms of your gut. And this is considered to be a key component of how symptoms appear and are maintained in patients with IBS. And not surprisingly, there's considerable interest from academics and indeed the pharmaceutical industry how we can use these targets to understand pathophysiological mechanisms and ultimately develop more targeted treatment interventions. So if we just go down to a smaller level now, down to the gut itself. And the gut is an amazing organ, and I would say that because I'm a gastroenterologist, but it is truly an amazing organ. It has its own nervous system, which we refer to as the enteric nervous system. And this has a substantial sensory innervation that conveys information from the gut up to the brain. But it also coordinates and integrates a bewildering array of reflexes and behavioral responses. And actually, there are more neurons in the enteric nervous system than there are in your spinal cord or indeed in the brain of a cat. So the gut is a very nerve-rich environment. So from the gut, these nerves can, broadly speaking, ascend to the brain in one of two ways, either via the sympathetic nervous system or the parasympathetic nervous system. And these two nervous systems have important features. So the spinal or the sympathetic nervous system really is involved in the perception of pain, inhibition of digestive function, so it slows the movements of the bowels down, in contrast to the vagal system, which actually is involved in physiological sensations, so hunger when you feel full, control of motility within the gut, but also can influence behavior and food seeking and so on and so forth. So actually the nerve communication to the brain is actually more than just pain. It's also involved in many other physiological sensations as well. So when it gets to the spinal cord, these nerves ascend in a number of pathways. I won't bore you with the details, but safe to say there are at least three main pathways in which these signals arrive in the brain. And within the brain itself, there are a number of important areas for the discrimination of pain. So the sensory discriminatory aspects of pain is the sensation and quality of the pain. The affective emotional, shown in these areas, is around how the pain makes you feel. And finally, the third dimension of pain is around cognitive modulative aspects of what that pain experience makes you learn. So I know that if I put my hand in some boiling water, it will hurt. So I generally will avoid doing that. And that's the cognitive modulative aspect of the pain. But as I said, this is a circuit of communication, and what goes up must come down. And again, there are three broad pathways that can modulate the amount of information that's coming up from the brain. So this is called descending inhibition. But if we bring that all together now, stress, whether that's pain, psychosocial stress, infection, activates a very complex response from the brain. mediated in part by the automatic or the autonomic nervous system with its two branches that I mentioned before, namely the sympathetic and the parasympathetic branches, which then impact on the enteric nervous system. But we also know this communication is influenced by personality factors. It can also be influenced by genes. And more recently, this idea that the bugs in the gut, the microbiota, can also change this communication as well. So what happens when this all goes wrong? So any disruption at any level of that circuit of communication can lead to symptoms which can change the speed of movements in the gut and lead to this concept called visceral hypersensitivity. So this is the leading hypothesis or proposal in explaining the development of symptoms of chronic abdominal pain. And this can happen either in the periphery or in the central nervous system and has been described in EDS. So what do I mean by visceral pain hypersensitivity? And I apologize, it's probably a little bit early to show you these kind of slides, but do bear with me. So the large bowel is composed broadly of 4 parts. So on the right-hand side you have the ascending colon, which then becomes the transverse colon, and then it comes down the left-hand side in what's termed the descending colon to the sigmoid and rectum, and then back to the outside world. And if you pay healthy volunteers and IBS patients enough to take part in these kind of studies, you can actually put a balloon in their tail end and begin to inflate the balloon. Then you ask patients and healthy controls then when they report pain. And this was perhaps the seminal study from Bill Whitehead in Chapel Hill, where he showed that patients with IBS were much more sensitive to balloon distension in their tail ends than normal healthy controls. And this is what we would term visceral hypersensitivity. So this increased sensitivity of the gut, in this case to mechanical distension, is actually very common in IBS patients. But enough of the science now. How do we manage the patient with chronic tummy pain? Well, I think it's a real challenge and often seen by many of my colleagues as a Cinderella speciality. And what I mean by that is that patients often get told there's nothing wrong, it's all in your head, get on with it, get out of my clinic. And actually that's no good for anyone, least of all the patient. And I think giving the EDS patient a GI diagnosis is actually key, because they've often been round the houses, and we spoke yesterday, and I think it's a lovely term of this idea of a diagnostic odyssey. And actually this is what we have to move away from now. And we can only do that really through more research and education. But I think the key aspect to managing abdominal pain well is actually the doctor-patient relationship. And many of us trot this phrase out ad nauseam, but I think it is absolutely key. And if you can explain to your patient many of these ideas, particularly around the brain-gut axis and visceral hypersensitivity, then this actually really takes you from a starting point which is much better and may improve outcomes. And I think, we can't do this all on our own, and I'm very lucky to have a clinical psychologist who works with me, as well as a specialist nurse who can help support patients through that journey as well. But also educating the patient as to the multifaceted nature of this disorder. So the problem might not just be in one particular place, and we need to adopt a global and a holistic approach to improving treatment, but also saying that, you know what, I have not got a magic wand that's going to make all your pain and all your problems go away. We can work together to make things better, but ultimately this is about setting rational and achievable treatment goals. So I think this is something that sadly many of you here today will be familiar with. So you have a patient who has chronic unexplained symptoms. They become pretty disenfranchised because they've seen lots of doctors who can't find anything wrong. The doctor gets frustrated. So what do? They do another set of investigations, another MRI excludogram to, testing another serum level of rhubarb, for example. These multiple investigations don't help anyone. And hey-ho, what a surprise, the outcomes to treatment are poor. So what does the physician do? Well, I've got nothing to offer you, I'm going to refer you on to Dr. X. And so the cycle continues. And I would argue that actually good management of EDS is not about drugs and anything like that. It's really around these three specific aspects, which I would regard as time, so spending time with your patients. And I appreciate particularly in the National Health Service in the UK, we're under increasing pressure to see our patients more quickly. You've got to empathise with your patients. You know, it only took me half an hour to get up and out this morning, but I imagine for some of you here this morning, it maybe took 2 or even 3 hours to get down here. So I think we as clinicians have to empathise with our patients and validate that the patient's symptoms are real. It's not all in the head. Of course it's not. Is some of it in the head? Yes, of course it is, because we're not just a set of joints, a GI tract, a cardiovascular system. We're one person. And I think that's absolutely key. But in terms of the pain itself, taking a comprehensive history, looking at some of the chronology of the pain, whether there's a relationship to surgery, infection, or in traumatic life events. And I think one thing that still fascinates me about this association between EDS and GI symptoms is that, you know, we're all born with our connective tissue. Yeah, and there's some patients who toddle along quite nicely with no symptoms at all. Something happens that then actually has a major impact on the development of symptoms. And what that something is, I think, remains to be seen. A few targeted investigations can be useful to exclude specific diagnosis, but actually fobbing the patient off with saying we're going to do more tests is not helpful. In terms of drugs, I do think they have a role. Particularly low-dose tricyclic antidepressants, particularly amitriptyline, is very good for pain management, and are some of the newer serotonergic, noradrenergic reuptake inhibitors such as duloxetine. I think psychological treatments also definitely have a role and a benefit, and also some of the newer therapies, so drugs like pregabalin and gabapentin also have a role. If we look at some of the literature in IBS, so this is a technique called meta-analysis. So investigators look at all the results that have ever been published on a particular subject, collate them all together, and see whether over a number of studies whether they work or not. And broadly speaking, if that little black diamond box is to your right, then the treatment works. And certainly there is a suggestion that tricyclic antidepressants can be very good for reducing global symptoms in IBS, but also pain as well. So actually these are very useful drugs. The precise mechanism of action is as yet unknown. I don't think these need to be high-dose drugs, but they should be used at night because they can make patients feel sleepy, and higher doses indeed may lead to worsening side effects. A word about the SNRIs. So serotonin and noradrenaline have been implicated in chronic pain mechanisms, and newer agents such as duloxetine and venlafaxine are promising. This small open-label pilot study, you can see here in the blue line, this is average pain scores, that over 12 weeks of treatment, these pain scores go down. Some of the newer treatments, gabapentin and pregabalin, have been used in a number of chronic pain conditions, perhaps most notably fibromyalgia. And certainly there's good basic information now in terms of those balloon studies in the rectum to suggest actually gabapentin can increase pain thresholds and make people less viscerally hypersensitive. I know that the Mayo Clinic uses a lot of quetiapine for pain management, and this improves global symptoms, but it's often limited by side effects. There are a number of psychological treatments out there which I think, again, have a major role. I think part of my problem in the UK is accessing these treatments, but certainly, particularly with the IBS literature, probably the best treatment that we have is actually gut-focused hypnotherapy. But again, it's limited by access and local expertise. And certainly, I think if you have a patient who's not improving after 3 to 6 months, then this is something you should think about. Some of the newer drugs that have been developed for IBS certainly worth a mention. There's a drug called linaclotide, which in the US I think its trade name is Linzess. This really simulates an infectious diarrhea to treat constipation. It largely stays in the bowel, so it's relatively side effect free. And I think it's got a very interesting mechanism of action that it produces what we call a secretory diarrhea by getting the gut to shift salts and water out into the gut to make stools softer and easier to pass. But it also, through a number of complex mechanisms, can reduce pain firing in the enteric nervous system within the gut. This has been nicely shown in the 2 phase 3 studies, both in the US. You can see here that linaclotide in the purple line versus placebo or dummy medication in the black line both caused a reduction in symptoms, but linaclotide was better than placebo over this 6-month trial. This was then repeated in another study, again in the US, which showed that linaclotide had a reduction in pain symptoms. But what was interesting in this study, after 12 weeks, the patients who were on linaclotide then got re-randomized to either stay on linaclotide or go on to placebo, and everyone who was on placebo then got linaclotide. And as you can see here nicely, those that were on linaclotide and then got placebo, the tummy pain started to come back, as shown by the black line from weeks 12 to 16. I just want to talk a little bit now about one of my major bugbears in pain management, particularly in EDS. This is around opioids and pain management. So opioids, strong painkillers, things like Oxynorm, Oxycontin, morphine, tramadol, etc., etc. And these have been the mainstay in the treatment of pain, particularly those patients with acute severe pain. Yet, whilst they're efficacious in moderate to severe pain of cancer origin, actually the amount of research showing that their improved quality of life and pain in the long term in non-cancer pain is absolutely limited. Moreover, actually opioids, many of their side effects limit their usefulness. They often make patients feel very drowsy. They have lots of side effects in the GI tract, and actually over time can worsen pain. And this is some data from the US looking at what's now termed the opioid epidemic. And as you can see here in the blue line, if you look at the deaths from heroin per 100,000 population in the US, there's definitely an increase from 2009 up to 2014. But if you compare that to the red line, i.e. the deaths from doctor-prescribed opioids per 100,000, that heroin line is absolutely below that. Okay, so my feeling is that actually lots of this is actually doctor, or what we call iatrogenic in its nature. And I think we need to think very carefully about starting these medications. They're really easy to start, very difficult to stop. And actually, if you think about these symptoms, or the side effects rather, of opioids within the GI tract, particularly in patients with EDS who already have many of these symptoms, you know, these side effects are common, affecting probably 90% of people who are on these medications, include constipation, nausea and bloating. So if you already have these symptoms anyway and you get put on one of these medications, it's going to exacerbate and make these symptoms worse. But there's no evidence to suggest that chronic opioids improve the quality of life, pain scores, or indeed your ability to carry out your activities of daily living. So there's this idea now that abdominal pain can be caused by opioids. And you'd be quite right to say to me, well, you've got a painkiller, how can that cause pain? But a number of mechanisms now have been proposed to suggest why actually patients on long-term opioids, their pain actually gets worse. And the opioids themselves can interact with the pain system, broadly speaking, through a number of mechanisms to make it more sensitive. There's this idea and this recently proposed diagnosis of narcotic bowel syndrome, which is characterized by worsening chronic abdominal pain, which is often treated with high-dose narcotics. Again, this is one of the problems that I think we're going to run into with many of our patients further down the line. And this is incredibly difficult to treat, and trying to detoxify patients off their narcotics and their opioids is very, very difficult indeed, certainly in my experience and that of others. So what are the pressing questions? So I'd like to give you the gastroenterologist's view of what the pressing questions are. So what will be the impact of the new Rome 4 criteria on GI symptoms in combination with the new 2017 HEDS criteria? And I think this remains an open question. My feeling is we've raised the bar in functional GI disorders and in IBS. I think actually GI symptoms will become even more common in those HEDS and patients with hypermobility spectrum disorders. I still don't think we fully understand the underlying cause of symptoms within the GI tract in patients with EDS, and I think this is work that's ongoing in our group at the moment. What are the ways of best managing patients? All the evidence I've presented to you today is derived from other conditions which may or may not be related to EDS in their underlying nature. So what is the best way of individualizing patients for EDS treatment in terms of their GI symptoms? And finally, how do we educate physicians and gastroenterologists as to the association between EDS and GI symptoms? That there's a clear association, and I think that's incumbent on the likes of me and others to try and spread the word. But I would have said if I'd given this lecture to a group of doctors 10 years ago, there would have been 3 or 4 in the room. But we recently had a symposium at the British Society of Gastroenterology where we had a room the size of this equally full. So I think the word is spreading and people are beginning to take this on board. So ladies and gentlemen, I know I've gone a little bit over time, but thank you for your patience this morning. I hope I've convinced you that GI symptoms are common and that abdominal pain is complex. I think treatment options are evolving, but doctor-patient relationship is key. Avoid opiates where possible, and we need to develop EDS GI specific treatment algorithms. Thank you very much indeed.
So, Adam, you've actually finished with lots of time.
So
sorry. You know what that means, lots of questions. The easiest thing to do, if you don't mind, is if everyone who has a question could come up to the front here, and then we can, and save me trying to look for hands and not knowing in what order people put them up. So I know there's some empty chairs if it's too much for people to stand, but that would also help me running around the room. Thank you. We shall begin.
What kind of structural changes do you see in the gut? How often have you seen jejunal diverticulum? And how do you treat bowel obstructions with this problem?
Okay, so should we sit down for an hour? In brief, so yes, I have seen duodenal diverticularly. They're often a cause of something called SIBO, small intestinal bacterial overgrowth, and SIBO that's often very resistant to treatment. The biomechanics within the gut can vary considerably between patients, but we at severe end of the spectrum we see EDS associated with chronic intestinal pseudo-obstruction. We also see it with changes in small bowel and gastric and large bowel motility. And forgive me, your third point?
How do you treat bowel obstructions with this problem?
With difficulty is the honest answer. I think lots of it's just supportive care, resting the gut. I often use prucalopride. It's called Resolor in the UK, which actually stimulates the gut as a propulsive agent, but doesn't work in all patients and can induce side effects.
If short-term narcotics have to be used for pain, how effective are narcotic antagonist drugs such as Movantik?
Okay, so can I just explain what Movantik is to the rest of the audience? So Movantik, or naloxegol as its trade name, is essentially the antidote to opiates. And the theory behind the development of naloxegol is that it's attached to a big protein molecule, so it doesn't cross into the central nervous system, what we term the blood-brain barrier. So you still get the beneficial effects in terms of painkilling as the opiates, but without the constipation. So I use a lot of Moventic. I think it's a useful drug. It comes as a once daily tablet. I don't think we use it early enough in the treatment algorithm, but hopefully there'll be a paper in the Lancet in probably 6 weeks or so, which will address some of those symptoms. But I do use it, and I think we should be using it much more.
How do you find the paper?
I'll send it to Lara.
Like I said yesterday, we have lots of medical articles on our website, so if you just look down at medical articles, you can find that and others there.
Yes, I was curious if there's treatment options for when your esophagus struggles to push food down, and there's no other medical explanation for it. And then my second one was whether there's any connection between increased production of stones, like gallbladder stones or kidney stones, and EDS.
So I'll deal with the second one first, if I may. So we haven't found any increased gallstones or the kidney stones in EDS patients when you control for age and gender. So they're both, so certainly gallstones are more common in females of later middle age. But when you control for that, we haven't seen a difference. The esophagus is very difficult to treat. So work from my colleague, Professor Daniel Sifram, has shown in EDS that actually the squeezes, the pressure of the squeezes the esophagus makes is much less, but we haven't yet got a specific drug that's going to improve the squeeze in the gullet. And my usual advice to my patients is eat smaller meals, chew your food well, take plenty of water with the meal, because you don't want to put the gullet under too much stress.
Hi, good morning. Can you tell me, please, how EDS affects the following? One, an elongated colon, the gallbladder, sphincter of Oddi, and the mesenteric artery.
Okay, so this is something I get asked an awful lot. So a patient comes to see me, they've had a colonoscopy for something completely different, and they come and say, oh, the doctor told me I had a large floppy bowel. I don't know what that means, in that normal length of the colon is has considerable variability between individuals, and I think whether patients with EDS have longer bowels, no one knows that. It hasn't been described as yet. Sphincter of Oddi dysfunction is a diagnosis that's made much more here in the US than it is in the UK. Generally speaking, it's a diagnosis that people tend to pick up after they've had their gallbladders taken out for another cause. Again, it's very difficult to treat. Opiates often make sphincter of Oddi worse because they cause spasm of the sphincter itself. The recent data from Peter Cotton in the US suggests that making a cut in the sphincter doesn't help any more than a sham procedure. So that's a study called the Episode study. You do have, so it depends what you mean by mesenteric artery syndrome. If you're talking about celiac axis stenosis and mesenteric angina, so patients get pain after eating, I don't see that more in hypermobile EDS. But certainly I have seen in quite a few patients with median arcuate ligament syndrome. So this is when one of the ligaments wraps around the mesentery. I have seen a few cases of those. Okay.
I'm just going to interject with a question that we get asked a lot, and I'm not sure where the research is on it. What do we know about GI association with the other rarer types of EDS at this stage?
Very little. I think you're right. That is one of the research questions, but it's about resource management, really, in the sense that there's not many of us doing it, and we've got to describe the common things first before we get to the nuances. The abstract I've presented from the Harvard group, Judy Nee's group, does suggest that GI symptoms a little bit more common in comparison to EDS 1 and 2 as they referred to it in that article. That's not been published yet, but it's in abstract form.
Thank you.
Could you please speak about the role of gluten in the diet?
Okay, excellent question. So I'm going to talk a little bit about gluten specifically, and then talk about diet generally, because I think it's a very important point. So there is a paper from a few years ago from an Italian group suggesting that celiac disease, which is an allergic response to gluten, is more common in patients with EDS. That data hasn't been replicated yet to the best of our knowledge and hasn't been our experience. But many of our patients say that actually, even though they don't have celiac disease, and we've excluded that, actually get better if they avoid gluten in there. They feel better off a gluten-free diet. And my view on these things always is that if I view it's not going to do you any harm and you get some benefit from it, then go ahead with it. And particularly this idea of a condition called non-celiac gluten sensitivity, which is gaining traction in the literature. Other dietary interventions, so there's a number of them out there, again, haven't been well studied in EDS. I can give you our experience from London. We find the low FODMAP diet. So FODMAP is an acronym for fructose, mono-disaccharides and polyols, which are essentially sugars which get fermented in the gut. Fermentation produces gas. Gas stretches the gut. That produces pain and discomfort. And that diet seems to be particularly helpful. For those patients with mast cell dysfunction, then a low histamine diet can be helpful. But again, these haven't been systematically studied. And I can give you my personal experience, but the hard evidence, I think, is just not yet there, and something we really need to look at.
And I just wanted to add, because I know that Professor Aziz is looking into this. I've spoken about this, and Dr. Collins spoke about it yesterday. Another area to look at, and it does need more research and evidence, is vitamin C high dose. I don't know if in your clinic you've had experience of that.
Casper and I profoundly disagree about this.
Right.
Which is good. I don't think it helps at all. He's a great advocate of high dose vitamin C because of its antioxidant properties. I think lots of it's how you phrase the question to the patient. I would say, this hasn't worked, has it? And he would say, did it work? Yeah, of course it did. So it's how you phrase the question, but again, needs systematic study.
Thank you.
Do you have any information on visceral hyposensitivity as opposed to hypersensitivity?
So in the study we published a few years ago with my colleague Mark Scott, suggested that there are some patients with EDS whose tail ends are undersensitive to putting a balloon in. Again, why that might be the case, we don't know. The majority were the hypersensitive end, but again, there's a spectrum. But there were some patients whose sensitivity was less. Now, is that a function of the connective tissue diagnosis? Is that a function of what drugs people were taking at the time of that testing? I think remains to be seen. But you're absolutely correct. There are a group of patients, particularly when we think about the tail end, whose sensitivity is less, for sure.
I wanted to ask if when you prescribe opioids to patients, or since that was a portion of your discussion, if you consider a couple of key points with this specific population. So you brought up the graph that showed the increase in overdose deaths from prescription narcotics. However, I wasn't sure if there was clarification that primarily a lot of those prescribed medications are abused or diverted, not taken as the patient is intended to be taking them. Also, a lot of them are related to illicitly manufactured fentanyl, which is not the same as physician-prescribed opioids. Additionally, the long-term studies on opioid long-term efficacy are pretty limited to the general population. And how do you take that information into consideration when considering EDS patients in particular?
I'm pretty clear on using opioids in pain management. I don't use them at all. I think there are much better ways of managing chronic pain. I'd agree with you entirely that much of that data is skewed by diversion, not using opioids for the prescribed indication. However, I would counter that argument and say that, particularly in the US, the development of OxyContin and Oxynorm and these kind of drugs has really probably fueled this. And the part of the problem is that we go back to the World Health Organization, the pain ladder, which you may have heard of, which is essentially a step-up approach to the management of pain. This was developed in 1982 for the treatment of cancer pain. Nothing about non-cancer pain. And to the best of my knowledge, it's never been validated in non-cancer pain. But every physician uses it in that context. Please don't think I'm saying that opioids don't have a role at all. I personally don't ever prescribe them. I think they should be used in the smallest dose possible for the shortest period of time. And actually, you know, in acute pain, they can be very helpful indeed. It's just in chronic pain, the number of patients that I've looked after who, forgive me for using this term, but I'm going to use it anyway, who become opioid cripples is remarkable. And this is all doctor-induced. And that's just a sad fact that doctors are trying to help, but in fact we're making the patient worse over time. I think in EDS, I think this remains to be seen, how best to manage particularly musculoskeletal pain. I can give you my experience in chronic abdominal pain in EDS that we just don't use opioids at all.
Yes, could you comment that is there a higher incidence of intussusception in adults with EDS and any kind of experience with that? Follow-up studies of pediatric patients, is there a higher incidence of EDS in those?
So the data suggests there probably isn't, but I see a number of patients who have, you know, recurrent episodes of intussusception. Some of those have first presented in childhood, and sometimes that's their first presenting feature actually of their EDS that's subsequently diagnosed. So again, particularly, our discussions yesterday were helpful that, and this is what we've got to get to doctors. You know, if you've got a young person, you know, a lady of 16 or 17 who has an intussusception or who has an unexplained rectal prolapse, you know, why would someone that age have those kind of that kind of presentation? So we have to take the next step and think, well, why has that happened? And that's one of the key educational aspects that I alluded to.
So for EDS patients that have had their gallbladder out, what after effects have you seen and what recommendations would you give to them?
So my feeling is that make sure the indication is really absolutely spot on to have the gallbladder taken out. A few stones floating around in a gallbladder, generally speaking, aren't going to do anyone any harm. An impacted stone or infection in the gallbladder, cholecystitis, is a different kettle of fish. But make sure that, you know, you're not getting a surgeon whipping the gallbladder out for a little bit of tummy pain that may or may not be related. Sphincter body doesn't seem to be more common in EDS patients. I think it's probably over diagnosed, poorly managed. Again, people often use opioids, which often makes the problem worse. What I do see quite a lot of, and this isn't just to patients with EDS, is patients developing diarrhea after their gallbladder's taken out. And they all get told that they've got IBS with diarrhea, go away and live with it, where in fact they actually have a condition called bile acid malabsorption, or BAM is its shortened name, which actually the treatment of that is very different to the treatment of IBS. And we published a meta-analysis a couple of years ago now showing that if you have 100 patients who have a diagnosis of IBS with diarrhea, probably 35 of them will have bile acid malabsorption. Why is that important? The symptoms are very similar. It's just the management is very different for those two conditions. So I do see a lot of bile acid malabsorption.
Yes, I have a 4, 6, and 10-year-old grandchildren who have EDS. The 4-year-old doesn't even like to eat anymore because he says that he'll get a bellyache from eating. Anything that can be done for them except Miralax?
So again, it's difficult for me to comment directly on the pediatric population because I don't look after these patients, but certainly I would suggest that you need to look into why that's happening rather than just throwing medications at it, and particularly some targeted motility studies can be quite helpful. One of the sad things that I see an awful lot in my patients who are transitioning from pediatric care into adult care is that you see a lot of patients who are diagnosed with an eating disorder who in fact are hypermobile and have delayed gastric empty or gastroparesis, so that their food can't exit from the stomach because the stomach doesn't contract, it sits there, that makes them feel sick, and then they're sick, and that those kind of patients I feel incredibly sorry for because they get labelled with a completely different diagnosis, which then often, if you say something enough, patients take it on board, and those group of patients can be very difficult to treat. But I would think about maybe other stimulants beyond just Microlax. Senna, Dulcolax. The newer drugs aren't licensed in children yet, so you're thinking of prucalopride, linaclotide and lubiprostone. I'm sure they could be used off-label, but there are things beyond just throwing more laxatives at patients. But I think the key question is to ask, well, why is this the case?
Hello. I was wondering if there was any studies or anything being done with GMO products and the fact that we're eating pesticides, foods that are labeled as pesticides like corn, and what it's doing to our gut flora, and then the fact that these companies are producing new bacterias and labeling them, and copyrighting them, and now that's changing our gut flora. My whole disease started with my gut by this.
So again, that's a really interesting. That's a really interesting question. That, again, to the best of my knowledge, there isn't any research looking at that. But as I said in my main lecture, that the question is, you have your connective tissue from birth. Not all patients have symptoms from day one, and actually, what's the trigger to turn someone from being functionally okay to having desperate symptoms? And I think that's one of the key outstanding questions in my mind. And I think the idea of GM foods as a potentially as a hypothesis to cause that trigger is certainly an interesting one. We have less GM foods in the UK, if any, and we still see the same prevalence of GI symptoms and EDS that you see here.
That and diet, cannabis and diet has been what's helped me. I've been able to I can get rid of IBS.
So cannabis can be helpful in chronic pain management. We have the nasal cannabis spray. Obviously, cannabis remains a Class C drug in the UK, so it's against the law. You're not allowed to use it unless it's for medical purposes. But one of the problems I find with cannabis use in EDS patients is they often get this syndrome called cannabinoid-induced hyperemesis, so they get lots of morning vomiting, which is relieved by a hot shower, which often then gets erroneously labelled as cyclic vomiting, but actually it's due to cannabis use. But that's not everyone.
Do you, in your experience, have you ever seen an association between malrotation, congenital malrotation, and EDS diagnosis later? And if so, do you have any suggestions post-resection of how to differentiate between the pain of dysfunctional bowel pain and a serious complication of the
So we've got one patient who came to us with their EDS diagnosis, but who had malrotation of the gut. So just to explain what malrotation of the gut is, essentially where the gut is transposed the other way around. So as the baby's developing in the womb, the gut doesn't quite twist properly to form its final resting place. It can be very difficult to treat when you've had a surgical resection, and differentiating sort of standard pain from obstructive pain can be very difficult in patients. The problem is the things people jump to as they come through the door of the ER is to do another CT scan. And this makes me really anxious, in particularly in our younger patients who come to me in their mid-20s and they've had 25 CT scans already. You know, this dose of radiation mounts up over time. I think something we need to be really careful about. By and large, in our patients, actually watching and waiting, symptoms usually subside on their own. And then if they don't, then that shifts the balance of risk and benefit towards cross-sectional imaging. But I think in terms of a technological development, you know, the next major kid on the block is going to be MRI motility studies. There's some great work going on in Robin Spiller's group in Nottingham, and indeed others, using this technique rather than esophageal manometry and gastric emptying studies and all the rest. I think this is going to transform our field from a measurement point of view. MRI motility. So it's using MRI to measure motility and function within the gut. I haven't seen any research from the US. So it's still in its infancy and it's not a clinical technique. But I think in 5 years' time, it'll be the go-to motility technique.
Okay.